Chapter 38 Immunosuppressive Therapies in Transplantation. Marcello here. Welcome back to Immunology Insights, Basics and Beyond. Last time we explored how the immune system, so essential for defending us against infections, can become a fierce adversary in the context of transplantation. We looked at the molecular and cellular mechanisms behind graft rejection, from hyperacute to chronic phases, and saw just how swiftly and effectively the body can destroy a life-saving transplant. Today, we shift focus to the defense systems that we can control, the pharmacologic tools and medication used to suppress the harmful immune response and protect the graft, and even further, how scientists aim to eliminate the need for these drugs altogether by training the immune system to accept the graft as its own. So let's talk science. Why does immunosuppression matter? Without immunosuppressive therapy, most organ transplants would be short-lived. The immune system is exquisitely trained to detect and eliminate anything foreign, including life-saving grafts. MHC mismatches, minor histocompatibility antigens, and donor APCs all provide triggers for immune activation. Modern immunosuppressive regimens, however, have dramatically improved outcomes. For example, 1-year survival for kidney transplants now exceeds 93%, and many grafts last over a decade. But managing immunosuppression is a delicate balancing act. Too little allows rejection to occur, but too much leaves patients vulnerable to infections, cancer, and metabolic diseases. Thus, immunosuppression must be personalized, monitored, and adjusted throughout the patient's life. What are the phases of immunosuppressive therapy? Immunosuppressive therapy is typically divided into 3 phases, each with its own goals and drug classes. First, induction, which lasts the first days to weeks after the transplant. The goal is to suppress the immune system aggressively during the period of highest rejection risks, right after transplantation, when the immune system is encountering the graft for the first time. Medication includes basiliximab, a monoclonal antibody that blocks the interleukin-2 or IL-2 receptor CD25 on activated T cells. By preventing IL-2 binding, it inhibits T cell proliferation without depleting existing cells, making it relatively well tolerated. Another phase 1 medication is antithymocyte globulin, or ATG, a polyclonal antibody preparation that directly depletes circulating T cells via complement-dependent lysis and opsonization. It's highly effective but can cause cytokine release syndrome and requires close monitoring. The second phase is maintenance therapy, which is lifelong. After induction, long-term graft protection requires daily medication aimed at different points in the immune response. Drugs here include calcineurin inhibitors, or CNIs. Tacrolimus and cyclosporine block the calcineurin pathway, which is essential for IL-2 transcription in T cells. By suppressing IL-2 production, they inhibit T cell activation at its core. Tacrolimus is generally preferred today due to a lower rejection rate, but both drugs can cause nephrotoxicity, hypertension, and neurotoxicity. A further class of medication for phase 2 are antiproliferatives. Mycophenolate mofetil, or MMF, inhibits the enzyme inosine monophosphate dehydrogenase, which is crucial for guanine nucleotide synthesis in lymphocytes. Since T and B cells rely heavily on this pathway, MMF selectively inhibits their proliferation. And then we have corticosteroids. Drugs like prednisone exert broad anti-inflammatory and immunosuppressive effects by downregulating cytokine gene expression and inhibiting multiple leukocyte functions. While often tapered over time, some patients require lifelong steroids. Last but not least, we have mTOR inhibitors. Sirolimus, which is also called rapamycin, blocks the mammalian target of rapamycin pathway, also called mTOR, halting cell cycle progression in T cells. Unlike CNIs, sirolimus does not cause nephrotoxicity, but it can impair wound healing, increase lipids, and delay recovery post-surgery. The third phase is rescue therapy for acute rejection episodes. When signs of rejection emerge, like rising creatinine, liver enzymes, or biopsy-proven immune infiltration, aggressive intervention is required. High-dose corticosteroids are typically the first step. In antibody-mediated rejection, therapies include plasmapheresis to remove circulating antibodies, intravenous immunoglobulin (IVIG) to neutralize immune activation, and rituximab, a B-cell depleting anti-CD20 antibody to stop antibody production. Rescue therapy aims to preserve the graft function and reset the immune equilibrium. As heard, there are quite some side effects that need to be managed. Immunosuppressive drugs come at a cost, and managing their side effects is central to long-term transplantation success. First, we have infections. Patients are vulnerable to opportunistic pathogens like cytomegalovirus or CMV, BK virus, especially in kidney transplant patients, and fungal or bacterial infections. Prophylactic antivirals or antibiotics are often prescribed during high-risk periods. Second, we have the risk of malignancy. Immunosuppression weakens the immune surveillance, increasing the risk of post-transplant lymphoproliferative disorder or PTLD and non-melanoma skin cancers. Regular skin checks and viral monitoring are essential. And third, there are metabolic toxicities. CNIs can induce hypertension, hyperglycemia, and dyslipidemia, contributing to cardiovascular risks. Long-term steroid use can lead to osteoporosis, weight gain, and glucose intolerance. Therapy must be tailored not only to prevent rejection, but to preserve the overall health of the recipient. There are also new emerging therapies. The field of transplant immunology is rapidly evolving. Several promising strategies aim to reduce toxicity and even eliminate the need for lifelong immunosuppression. First, we have belatacept. This fusion protein blocks the co-stimulation between CD80, CD86 on APCs and CD28 on T cells, a critical second signal for T cell activation. Belatacept is less nephrotoxic than CNIs, but may carry a higher and early rejection rate and is only approved in Epstein-Barr virus seropositive patients due to PTLD risks. Second, cell-based therapies. Regulatory T cells or Tregs, which naturally suppress the immune responses, are being studied for tolerance induction. By infusing expanded Tregs, researchers hope to train the immune system to accept the graft as self, though still experimental early trials show promise in reducing reliance on drugs. To conclude, immunosuppressive therapy is both a shield and a sword, protecting grafts from immune destruction but introducing its own set of challenges. The art of transplant medicine lies in finding the sweet spot between protection and oversuppression, a balance that requires vigilant monitoring, individualized care, and often multidisciplinary teamwork. Thanks to this therapy, organ transplantation has become a life-saving routine for patients with end-stage kidney, liver, heart, and lung disease. But it's not a cure. It's a lifelong condition managed with powerful medication, regular follow-ups, and a partnership between patient and provider. In the next chapter, we will venture into the holy grail of transplantation, tolerance induction. Can we train the immune system to accept the graft as self, eliminating need for chronic immunosuppression altogether? The science behind it is fascinating, and the future may be closer than you think. Before closing, I have a small request. If you enjoyed my content and want to hear more, like and subscribe. It's a small step for you, but it helps me a lot. So, see you next time, and thank you for listening.